Welcome, everybody. My name is Gilberto Lopes. I'm a medical oncologist at the University of Miami Sylvester Comprehensive Cancer Center. And today we're going to be seeing what happened in the last few months in regards to COVID-19 and cancer. This has been a very eventful year. We have lived through a pandemic, which has affected us in our professional and personal lives. Many of us have had family members, and even some of us got sick with COVID. And we hope that everybody, as much as possible, recover, that the world will go back to normal. In the meantime, we have adapted to the new situation. And what I'm going to be discussing today is what we have done and what the impact has been of COVID-19 and cancer. This slide just shows a general panorama of the distribution of COVID-19 deaths worldwide as of September 2020. We can see that the Americas have been very heavily affected, as have every other continent in the world, with the exception of Antarctica. The mortality for cancer patients with COVID-19 remains substantial, and this certainly underlines a critical issue because of multiple risk factors that our patient population has. The very first article reporting on just 18 patients in China suggested that patients who had no cancer had better survival and were less likely to be admitted to ICUs or to the hospital than cancer survivors and patients with cancer getting treatment in general. But that was a very small study that actually started many important efforts. One of the replies to that specific publication was this tweet by Dr. Akash Desai, who now is a fellow at the Mayo Clinic in Rochester, mentioning that COVID-19 and cancer is an important issue and that we had very few data to suggest what we should do and to guide what our new interventions should be in this era of the pandemic. And that was one of the efforts that started with that tweet, was the origin of the COVID-19 and Cancer Consortium, which now includes more than 100 institutions around the country. I'm going to be talking a little bit about this in more detail because I'm one of the steering committee members for this initiative. But we have also had a number of different efforts. In lung cancer in particular, the TerraVolt collaboration has been extremely successful, as have efforts led by ESMO, by ASCO, and there's a very important study being done by the NCI, as we're going to see in the next slide, which not only tries to gather clinical data, but also has correlative studies. And this is actually a longitudinal prospective study that hopefully will even shed more light, to what we are doing today. And this is a summary of what we're going to be discussing today. The impact of COVID-19 on the delivery of care, the psychological impact, not just on patients, but also on us caregivers, the impact, as I mentioned, on healthcare workers, outcomes and prognostic factors that we have learned over these several initiatives that have launched earlier this year, the impact of anti-cancer therapies on COVID-19 outcomes. Is it safe to give chemotherapy? Is it safe to give immunotherapy? Is it safe to continue targeted agents? We're going to discuss a little bit in particular about COVID-19 and lung cancer because we have specific data on that situation. And we will very briefly, with only slide only, talk about clinical trials issues and eventually brought this call to a close with a summary. I'll start with disparities. This was presented at ESMO in the virtual meeting this year. Dr. Dora Shaw was the main author, and this is a study called CCOS, COVID-19 and Cancer Outcome Study. This was a multi-center prospective evaluation of the impact of the pandemic on cancer care delivery and outcomes. This was a cohort comprised of consecutive outpatients with active cancer or a history of cancer that were seen at two institutions, Mount Sinai and Dana-Farber, and the data were collected at baseline, whatever had happened 3 months before and 3 months after the baseline. The primary endpoint was the impact of COVID-19 on clinical care, including the number of outpatient visits, the number of telehealth visits, as well as looking at the outcomes of patients who developed COVID-19 and what were the pandemic-related delays of planned oncology care. This is the study design in a graphic fashion, showing that the dates of study were March 2 to 6, and authors went back to December 2nd and forward to June 6 to see what happened to these patients. They collected data on 2,365 patients, and they had a median follow-up of 84 days. And there were a variety of patients, about half and half female and male, preponderance of white non-Hispanic patients, but also had 12.6% of Blacks and 12.6% of Hispanics, as well as other patients. And malignancy-wise, these tumors had genitourinary, hematological, breast, and thoracic, as well as GI, head and neck, and other tumors. The main findings of this study was that 51.6% of patients had decreased number of in-person visits in the pandemic period, so about half of patients have been affected in these two institutions, and 32% had an increase in the number of telehealth visits. Importantly, Black and Hispanic patients were less likely to have an increase in telehealth visits and were more likely to have COVID-19, which actually increases the prospect of disparities that are based on ethnicity related to COVID-19 and cancer. Also, Hispanic patients were more likely to have treatment delays than white patients, and a minority of patients actually were the ones who experienced a very disproportionate burden of cancer care disruptions. As such, we need to carefully design interventions that should aim to narrow these disparities in care delivery. In addition to that first study, the second study that was extremely interesting with a similar subject was the COVID-PACT study, also presented at ESMO. And this looks into the impact of COVID-19 on the management of medical cancer treatments, as well as the psychological consequence for the patients, which is what this study adds to the one I just mentioned. This is an ongoing study. Patients in an outpatient department in medical oncology were enrolled, and they were asked to complete self-questionnaires on stress, sleep quality, quality of life, and cognition. And all of these are validated instruments that have been used in different studies in the past. There was also data collection of medical records. These were done in France. And we also see that the authors collected data on caregiver impact. And here caregiver is healthcare workers. And they also looked at stress, scale of professional exhaustion, and the feelings of personal efficiency or not, using validated instruments as shown in the table. The main endpoint was the proportion of patients with medical oncological treatment that had modifications in the treatment or follow-up that was linked to the pandemic. And the secondary endpoints included the psychological impact of the pandemic among cancer patients and medical oncologists, and also oncology daycare unit caregivers. This is a summary of what the questionnaires were and how many items and what the scores usually are, and if they were applied to patients or to patients and caregivers as well. So eligibility criteria were patients that had a solid or hematological tumor and that had treatment carried out at the daycare hospital initiated before or during the pandemic, and the patient agreed to participate. For the caregivers, which were 73 versus 735 patients, these were medical oncologists, hematologists, interns, nurses, and caregivers in the day hospital that agreed to participate. The sample size was calculated as at least 385 patients to estimate the rate of lockdown-induced treatment modifications with 5% margin error, and data were collected for 621 patients, and that's what was presented at ESMO. Median age, the age, 29% of patients were older than 65, 25% younger than 65. In terms of treatment modifications, patients had about 25%, whatever the metastatic or localized status were. And patients with lung and head and neck cancer actually had more modifications of their treatments. These are the types of treatment modifications that we're seeing in this study. About 30% had adapted monitoring, meaning instead of coming to clinic, there were phone consultations or telemedicine with video consultations. 15% had treatment interruptions. 32% had treatments postponed. And for 19%, the rhythm or the frequency of the treatments were changed as well. For patients who were actually diagnosed with COVID, which were only 2 patients in this series, chemo was postponed for 1 patient and no modification of immunotherapy was made for the other patient. Of those 27% of patients who had treatment modifications, 21% in first line, 31% in relapse, 18% for chemo alone, 23% for chemo and others, 49% for immunotherapy alone, and 47% for targeted therapy and others. There were only 18% of chemotherapy alone treatments were modified, which is an interesting number as well. This brings us to the psycho-emotional status during lockdown. There was clearly high level of stress among patients because of the pandemic. And this, of course, was even higher for those patients who had modified treatments. And we could see that in all three scales, including stress related to event, perceived stress, and insomnia instruments. For patients' quality of life using FACT-G and FACT-COG, we also did see, we saw that actually the treatment modifications had no impact on the quality of life of these patients using these instruments. We did see an increase in stress, but quality of life did not really change that much. For caregiver, emotional, professional, and personal accomplishments, we see that there were high levels of perceived stress, but these high levels were also, we also saw high levels of professional accomplishment and personal self-efficacy. So it's a moment of stress, but that led people to overcome some of this stress. And in the end, most of the interviewees were actually feeling that they had accomplished something and that personally they had a benefit from this accomplishment. We see on the right a table with the specifics about this emotional exhaustion, depersonalization, and personal accomplishment. And we also saw that there was a higher level of perceived stress among caregivers than among patients themselves. The conclusion about this series, again, these are relatively small series. These are all very interesting but very preliminary results. And they suggest that during the lockdown, treatment modifications did lead to patient stress, and caregivers also expressed a high level of stress, but mainly due to the sense of being important in the system and stress, caregivers reported high levels of self-efficacy and professional accomplishment. We have to remember, and that's what the authors suggest, that COVID-19 pandemic is not over, and they will continue checking the psychosocial parameters over time. So we look forward to seeing how things progress as time goes by. ESMO also led a study on the impact of COVID-19 on oncology professionals so that we can see if those results are validated on a different cohort. This was a collaboration of key ESMO groups and the OncoAlert network. There were 2 surveys between mid-April and early May and mid-July to early August 2020. And the key outcomes of interest here were similar to what we saw in the previous study, just using a slightly different instrument. So authors checked well-being slash risk of distress using the EWBI, the Wellbeing Index. Burnout was evaluated as a single item, and COVID-19 job performance was evaluated as if the standard of cares were followed and job delivery compared to the pre-COVID-19 era. These are the results for survey number 1. There were 1,520 participants from about 101 countries, so this is about 3 times as large, 20 times as large in terms of caregivers participating as compared to the study we just showed. Most came from Europe, but a few came from Asia, North America, South America, Africa, and Oceania. And there was an interesting finding that the well-being and COVID-19 job performance varied between countries and were related to COVID-19 mortality rates. So it seemed that, of course, in those areas where we had more COVID, you had more interesting results as well. How did professional duties change since COVID-19 started to become an issue? There were more remote consultations. 50% of people suggested that. 11% of colleagues who answered also had to cover non-oncology specialties. 33% had more hours working from home. 38% perceived that there was reduced clinical trial activity, and 16% had participated in COVID-19 related research. Overall, 67%, 2 out of 3 colleagues reported a change in the way they were practicing during COVID-19. 24% had been redeployed in different capacities, and about 45% thought that the training for that redeployment was not adequate. So we do have a lot of work to do should we get a second wave when winter months come in the Northern Hemisphere. This is survey number 1, the results for well-being. 25% of participants had a high EWBI score, indicating higher risks or worse well-being. And to the left, you can see the specific questions that are asked, and to the right, you can see the distribution of the scores. What were the predictors of well-being, burnout, and job? So here in this first table, we see the results for well-being. Those individuals who had more resilience, who were valued by their organizations, who had pleasant working conditions, who were older than 40, who were men, and had change in physical activity, did better in terms of well-being. And being worried about current well-being, having increased number of hours, being concerned about the impact of training, own training and career, the need to self-isolate, and avoiding thinking about it, changes in diet, reduced clinical trial activity, and talking to colleagues to get emotional support actually decreased colleagues' well-being. In terms of burnout, non-white ethnicity, pleasant working conditions, resilience, and support by governments decreased burnout. And having a personal psychiatrist, which of course is a risk factor if you are feeling worse, you look for care. But having increasing numbers of hours of work, being worried about the current well-being, have more out-of-hours work, and concern about the impact on training and career were all factors that were associated with more burnout. Finally, in terms of COVID-19 and job performance, those that had adequate control of their job, had more resilience, were surgical oncologists or hemato-oncologists, had better job performance, or at least perceived job performance, and those that were worried about the negative impact on cancer research, the crude mortality rate in the country of work, more hours working from home, distractions, reduced clinical trial activity, and non-white ethnicity were all associated with worse COVID-19 job performance. Conclusions from this study: this is the largest COVID-19 survey series in oncology professionals. Of course, the number of participants in individual countries is relatively small, and that impairs our ability to see exploratory analysis from this data set. Well-being and job performance varied highly between countries and was related to COVID-19 mortality rate. But clearly, COVID-19 is impacting well-being and job performance, and the main predictors of well-being, burnout, and COVID-19 job performance were resilience and change to work hours. The risk of distress and burnout increased during the COVID-19 pandemic, but the perception of job performance also improved. Further analysis, including details of gender and age response, are underway and should be reported in future meetings. And of course, there is an urgent need for us to address well-being and improve resilience of our medical oncology, hematology, and cancer workforce in general. That brings us to another topic. How do patients do if they have cancer and develop COVID-19? This is the presentation by Dr. Grivas at ESMO 20, and this is a presentation from the COVID-19 and Cancer Consortium. This is the latest update. The data for COVID-19 and Cancer Consortium were initially presented at ASCO, published in the Lancet, and this is the updated data set as I'm going to show you. These are the participating institutions in the United States. There's also participating institutions in Spain and in other countries, and those data are being added as we move forward. And the bottom graphic shows the cumulative complete cases accrued over time. When we did the data cutoff for ESMO presentation, we had a total of 5,000 plus surveys. After exclusions, we had 3,899 patients included in this analysis. At the very bottom of the slide, we see the all-cause 30-day mortality at 15%. And we see that 25% of patients with COVID-19 who developed cancer were hospitalized during the period of the study. Risk factors that were associated with 30-day all-cause mortality include aged. By every 10 years, we had a 70% increase in mortality. For male sex, we had a 50% increase in mortality. For Black versus whites, a 50% increase in mortality. For ever versus never smoker, a 30%. Patients who had 3+ actively treated comorbidities had twice the risk of death, and patients with a performance status of 2 or more versus 0 had almost 5 times higher risk of dying if they had a performance score of 0. In the specific series, we have different mortality by different cancer types. We had 82% of patients with solid tumors, 22% with hematologic, and 12% of multiple cancers. 21% had breast, 16% prostate, 12% GI, 11% lymphoma, 10% thoracic, and 6% multiple myeloma. And on the right, we see the mortality for selected cancer types. We see that overall, the mortality has been, this was the report before ESMO, so 16%. For patients with breast cancer, the mortality was only 8%, prostate cancer 18%, colorectal 19%, lymphoma 22%, and lung cancer 26%, which is very close to the numbers we're going to see at the specific lung cancer database Teravolt in a few minutes. Other risk factors: patients who had progressive cancer were more likely to die, almost 3 times as much if they developed COVID-19. Recent therapy did not statistically significantly correlate with overall mortality, but did correlate with hospitalization. Patients with hematologic malignancies versus solid tumors had higher mortality, and those patients that had had a history or that had several active cancers versus one also had increased mortality. These are the lab correlates. We did see that increase in neutrophil counts and decreases in platelets, abnormal creatinine, abnormal D-dimers, abnormal troponin, and abnormal C-reactive protein, all correlated with worse mortality. The conclusions: general factors, as expected, older age, male sex, more comorbidities were associated with increased mortality, as were cancer-specific factors. If you had a performance status of 2 or more, if you had progressive cancer, if you had more than 1 cancer, or recent therapies, you did have higher hospitalization and maybe increased mortality as well. Low absolute lymphocyte count, high or low neutrophil count, low platelets, abnormal creatinine, D-dimers, troponin, and CRP were all associated with increased mortality in this exploratory analysis as well. And we will continue working on doing modeling so that we can continue to generate insights from this database. And I'm going to be showing one more study based on COVID-19 and Cancer Consortium. But first, I want to show you a database from Europe, mostly from the UK, looking at 7,000 hospitalized patients, because the data I showed you so far, all patients had cancer. What's interesting about this study is that it looks into patients that got admitted to hospitals overall with COVID-19, and it looks at patients who did have cancer and who did not have cancer. So this gives us a better idea of what the relative risk of having cancer is, and not specifically what the risk factors are for patients with cancer. This is a global effort, but the data were mostly presented for patients in the UK. 60,000 patients had no cancer, about 5,000 had a history of cancer. And when we move forward, we see here that the hazard ratio was 1.62. So patients with cancer had a 40% 30-day mortality versus 28.5% mortality if they did not have cancer. And you see the corresponding graphic in this slide as well. Based on this large prospective UK series, 10% of hospitalized patients with COVID-19 had cancer. There were no clinically significant differences in the presenting symptoms between patients with and without cancer, but there were significant differences in admission to critical care, mechanical ventilation, and other factors for patients with and without cancer. Those with a history of cancer at least had a worse survival than those without any history of cancer. And the impact of cancer on survival was greatest for those patients with age less than 50. There were, however, a number of issues with the study. There was a lack of information around cancer types, stage, and treatments, so we cannot have a more granular description of what the determinants of risk are for patients with cancer. That brings us to the specific lung cancer database, the Teravolt investigation. And the main gist of this presentation is that patients with thoracic malignancies have an even higher risk of COVID-19 related mortality at 32% as compared to other patients with cancer, as we saw in the slides earlier. And for patients with lung cancer, age, smoking, stage of cancer, performance status, prior steroids, and the class of anti-cancer systemic treatment did seem to be variables that were related to COVID-19 mortality. But ECOG performance status before COVID-19 is by far the most important factor in this database. And investigators also created a nomogram that could be used as a predictive mortality test for patients with thoracic malignancies who developed COVID-19. This brings us to one more of the studies by the CCC19 registry, and this is an analysis of what systemic cancer treatment-related outcomes were for patients who developed COVID-19. These were the most frequently administered anti-cancer agents in the cohort: chemotherapies, especially cyclophosphamide, carboplatin, paclitaxel, and doxorubicin. Targeted therapies were more typical for hematological malignancies than for solid tumors, and immunotherapies included pembrolizumab, nivolumab, and other PD-1 and PD-L1 antibodies. For breast cancer patients, most commonly used treatments were leuprolide, and as for endocrine therapy, leuprolide, anastrozole, tamoxifen, and others non-specified. This analysis is in the 1,449 patients that were treated within 3 months of a COVID-19 diagnosis. Of these, 19% were in remission or had no evidence of disease, and for these, the mortality was only 6%. For patients with any active cancer, the mortality was 22%. For those patients who were responding, mortality was 14%. For those who were stable, it was 18%. And as I mentioned before, for those patients who were progressing, the mortality was 34%. So patients who do not have good control of their baseline cancer are at much higher risk of dying if they develop COVID-19. And these are the data for 30-day mortality, but the most recent treatment type. We see that untreated patients had a mortality of 14%. The highest mortality at 30% was for patients receiving chemo and immunotherapy. And then we see intermediate mortalities for those only on chemo, only on IO, on chemoradiation, on targeted agents, or on endocrine therapies. These are standardized mortality ratios, and we see that that effect of chemoimmunotherapy combination and mortality did hold with the hazard ratio of 2.11. And we also see that targeted therapy was correlated, but again, the agents being called targeted therapies here are not the specific ones we see in lung cancer, for which mortality seemed to be less compared to chemotherapy and chemoimmunotherapy. These are drugs like rituximab or other anti-CD20, and this may reflect more of the effect of these drugs on the immune system rather than the cancer itself. So these are data that we need to take a better look at, and before we can make any conclusions about what treatments patients should continue or not. Conclusions, limitations: the 30-day mortality was highest amongst cancer patients treated between 1 and 3 months prior to the COVID-19 diagnosis. For these patients, all-cause mortality was 28%. The unadjusted 30-day mortality was highest for those patients treated with chemoimmunotherapy at 30%, but mortality was especially high in patients receiving anti-CD20 1 to 3 months prior to the diagnosis of COVID-19, which is exactly the time period for which significant B-cell depletion develops. And finally, mortality was higher for those undergoing active treatment, except for endocrine therapy, compared to patients untreated within a year prior to COVID-19 diagnosis, suggesting that all of our efforts of trying to prevent COVID-19 infection in patients getting active cancer is certainly something that we have to continue doing. Limitations: this was a retrospective study with descriptive statistics, and we do have missing data points within the study. What has happened this year with cancer clinical trials? This is a slide showing that initially we had a decrease in the number of clinical trials being run, and then over the course of the year, we're seeing more trials restarting or being initiated. We're going to focus on the bottom left where we see oncology trials. In January, there were about 500 trials going on in the areas that were evaluated in this study at Nature Reviews Drug Discovery. By April, those numbers had dropped to 323, and in July, those numbers were up to 608, showing an increase of about 22% over January, which means that we did have a lull. We did have to make changes, and we had to adapt in clinical trials as we did in general clinical practice, but we're seeing a large number of trials that have been continuing and being developed even during the pandemic, and that brings a lot of hope. Summing it all up, what have we learned about COVID-19 and cancer? The COVID-19 pandemic has definitely disrupted cancer care. This again is a study showing that out of 120 countries, reported that non-communicable disease services have been disrupted. We see the arrow pointing at cancer treatments, showing that between 40 and 50% of all cancer treatments have been either postponed or interrupted. Oncologists and healthcare systems, however, have adapted tremendously and amazingly how they deliver cancer care to mitigate the increased risk of morbidity and mortality. Telehealth has become widely adopted, both in low and middle income countries as well as in higher income settings. And I'm going to show you a slide about that. But in patients, in general populations, patients of racial and ethnic minority groups have been disproportionately affected, not just by COVID-19, but also by our ability to reach them during the pandemic. In terms of well-being for patients and providers, this is our take-home message slide. COVID-19 has had a major impact in our psychological well-being, both as patients as well as cancer professionals. We have had a lot of expert opinion, and we're now starting to see some evidence, but we clearly need a lot more study to be able to make better treatment decisions, to reassure patients about their treatments, and how to make sure that we become more resilient and can continue delivering care through these difficult times. We also need to thoroughly assess the psychological impact of COVID-19 in patients, and we in particular need to have prospective ways of evaluating treatments and support for the psychosocial distress that many of our patients have been developed. It's extremely important that we avoid a wave of post-traumatic stress for our patients and our healthcare professionals as well. In terms of the associated risk factors with severity illness from COVID-19, this slide summarizes what we have learned. We have seen an impact of age. We have seen an impact of concomitant medications. We have seen a very large impact of social disparities, race and ethnicity, smoking, comorbidities, as well as whatever treatment it is that patients need to control their cancer as well. These disruptions that we have seen, unfortunately, affect patients of minority groups and patients in greater need more than patients that are white or are in high-income countries, and this is certainly something that we need to address moving forward. But in summary, we have made a tremendous effort over the last several months to be able to disrupt as little as possible the treatment of our patients with cancer. That has taken a toll not just in their psychological well-being, but also in the well-being and the stress level of healthcare workers. And we clearly need to continue doing what we're doing, and we have a lot more work to do to be able to control the pandemic and continue trying to control cancer around the world. I'm going to stop here. I'm available for questions through email and through WhatsApp messages. Please do feel free to contact me should you have any further questions or any concerns or any curiosities about COVID-19 and cancer. Thank you very much for your time, but especially for your service day and day with our cancer patients.